Bismillahirrahmanirrahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Hi dear third year medical students. We will talk today about overweight and obesity. What do you mean by overweight and what do you mean by obesity? Obesity is a medical term for over fatness and accumulation of adipose tissue. Usually the body weight increases by 20% more than the ideal body weight, and it is regarded as a chronic disease and carry complication and might end with death. While overweight, there is excess weight and for height by a standard table, and it equals to 10% or more of the ideal body weight. So there are differences between obesity and overweight regarding to the percentage of increase or increment of the weight more than the ideal body weight. In obesity it is 20% or more, and in overweight it is 10%. And we have to remember that in most individuals, overweight and obesity are related except in athletics, where the patient are overweight. Here the person is not a patient now, he is athletics, and the overweight is regarded or related to the increase in the lean body mass. He is not obese. And on the other hand, the reverse is happened. Some of the inactive individuals, they are inactive. They are not athletics and they have little mass, but they are obese. And even when they are obese, they are not overweight because the bulk of mass is very minimum. What do you mean about ideal body weight? It is the body weight for a given height, and it is statistically associated with the greatest longevity. So the optimal body weight that have a good health and optimal life is we called the ideal body weight. This is the ideal body weight chart, and here we have for male and female. The height is estimated here by feet and the weight by pounds and kilos. We can depend on this table to know the ideal body weight for each person. So how many types of fat is present in our body? There are two types. The essential fat, which is vital to health, and it acts as cushion to protect the body organs. It equals to 3 to 8% of body weight. And we have the storage fat, which is layers and cushions of fat, which is providing stored energy. So essential is essential and vital, while the storage is only supplied energy. Gender specific fat. In women, there is fat accumulated in certain places like in the breast and in pelvic region. And the normal proportion of body weight as fat is equals to 15 to 20% for male, and it is 20 to 25% for women. What do we mean by that? We mean that 15 to 20% of body weight is fat in men, and 20 to 25% of body weight is fat in women. Now, during 20s, man has 15% body fat, and it is divided to 3% essential and 12% storage fat. In women, the storage fat is the same, it is 12%, but the difference here in essential fat, it equals to 13%. So the total fat present in women is 25% of body weight. Most girls do not begin menstruation unless their bodies are at least 17% body fat, and they do not continue regular period without 22% body fat. This can show the muscle fat analysis. Here we can assume that the man, anyone male, he has skeletal muscle mass more than female, and the fat is less, while here in female usually the fat is more than muscles. So regarding epidemiology, usually the prevalence of obesity all over the world is increasing, and mainly in USA. And the mortality here, we have to remember, this is important subject. Although the rate or prevalence of obesity increasing, but the rate of mortality is decreasing in women over 45 years. This is the high prevalence group. The prevalence of obesity in Western world begins in infancy, and 30% of infants are obese. And in school children, they found 6 to 15% are obese, adolescent 20 to 30%, and 80% of obese adolescents become obese adult. And the more the obesity in childhood, the more the obesity in adulthood. And the women are more likely to be obese more than young men. Young women are likely to be obese more than young men. The obesity also increases the risk in young adult than older adult or older people. Epidemiological studies show that there is a strong association. It is important to know there is a strong association between socioeconomic status and the prevalence of obesity, although it is inversely related. 30% are obese of the low social economic states. 30% of them are obese. The higher incidence among ethnic minorities like cultural, behavioral, religious practices, they seem to reflect combined genetic and environmental influence. This is regarding the epidemiology. Now, the causes. Either it is metabolic, when there is excess of calories that required to meet metabolic demand is stored as a triglyceride in adipose tissue. So it is metabolic. They eat a lot of food and more of that is stored as triglyceride. Or sedentary lifestyle, and emotional when there is impaired self-image, self-confidence, and feeling of inferiority. This leads to social isolation and start overfeeding. And number 4, acquired from family, genetically predisposed. And this genetic predisposition, approved by many studies, it shows that 2 obese parents have a 73 chance of having obese offsprings. If one of the parents is obese, the chance decreases to 41%. And if the parents are lean, 2 of them are thin or lean, they have only 9% chance to have obese offspring. A strong correlation found in identical twins. So this is regarding the family, genetically predisposed family history for obesity. And other cause for obesity, they blame to brown fat. Here we have some people, you have seen many peoples or some peoples, they eat a lot without gaining weight because of the presence of high brown fat in their bodies. They are thin, they are normal, but never gaining weight and never be obese because of the presence of high brown fat, high amount. What is the brown fat hypothesis? It says that the cytochrome pigmented brown adipose tissue, which occur only in certain areas in the body, around the neck and the chest, it is not developed after birth. These tissue rich in mitochondria and they produces heat. It serves as a caloric buffer. It change and correct buffer which correct the calorie system. That they disposes energy excess when food intake is high, so they burn it in high amount, and conserve energy when the food intake is low, to preserve energy. So it acts as a calorie buffer. In obese patient, there is defect in the brown adipose tissue, or in amount, fewer brown fat cell may be responsible in part for obesity. This is the brown fat theory. And here we have the mitochondria. It is very active in this type of adipose tissue. We call it the brown adipose tissue. It is only found during infancy and during intrauterine life, and it remains constant in the same position. Other lipoprotein lipase theory, it can potentiate hunger. It can potentiate hunger and rate by changing the availability of circulating metabolites, and this will make the person eating a lot because he feels hunger all the time. 7th rule of leptin. There is a lab experiment done in which they suspect there is a mutation in gene of obesity. This mutation will cause hereditary type of obesity. They do it in mice in a lab experiment, and they took the protein of Ob gene, we call it the leptin H. This protein is regulate the amount of body fat through control of appetite and energy expenditure, which means loss of energy or preserve energy. So control of appetite is a function or the job of this leptin. Leptin secretion is suppressed by feeding, and leptin secretion enhanced by starvation. In the experiment, they did inject the mice with leptin. It showed that later on, the mice decreases its food intake, and there is thermogenesis increases, and then end with a weight reduction. So when they have high leptin, these mice become thermogenic, and the food intake is decreases and the weight also is decreases. While in obese patients, as in this obese mice, they found that there is inactive gene, leptin gene, or it is not present at all. This theory regarding role of leptins. So regarding the classification of obesity, there are different classifications. First of all, the hypertrophic obesity, it is a result from an increased lipid content of the adipocyte. Usually it is mild to moderate obesity and is common in adults, not in pediatric age group. Hyperplastic hypertrophic obesity, there is an increase in number of fat cell and an increase in lipid content of the fat cell. This is because of overfeeding during infancy and adolescence, and this will end with a permanent abnormality. So, therefore, the preventive measure should be taken during these periods. So we have two types according to the type of fat cell present. Either it is hypertrophic or it is hyperplastic hypertrophic obesity. There is other classification depending on the regional fat distribution. Either it is android or gyroid. Android, apple shape. Here the fat is condensed in the upper part of the body, and we call it the upper body obesity. There is excessive fat located in the central abdominal area, which is statistically associated with an increased risk of diabetes mellitus, hypertension, cardiovascular disease, and it's common in male. So this is the type, as we said, common in male. We call it the android or the apple shape. And here it is accumulated in the abdomen. It is condensed, or the fat is accumulated in the abdomen, and this will cause and carry many complications. Gyroid or gyroid is a pear shape. Here it is in the lower part of the body, and mainly in the lower extremities, around the hips and femoral region, and relatively it is benign, and it is more in female, more common in female. So how we assess obesity? First of all, by taking the body weight. We have to check the body weight and to compare, and we have to compare this with a table of standard values, and we depend on the, as we said, the ideal weight for that age and for the sex. And we have to use the liver balance type scale like this one. While the height measured by using the horizontal arm, this is that we can move it vertically on a calibrated scale. And we have erect. The patient should be in erect position, heels together, and against a straight surface with a head level without shoes. So we have to take the body weight and the height and the body mass index. What we mean by the body mass index is a ratio of weight in kilograms with a minimal clothing to the height in meters square without shoes. So the body mass index, we can use it as a screening for test for overweight or obesity. So the weight by kilograms over the height by square meter is the body mass index. And we have certain readings. For each reading, it gives the clue to the probable diagnosis, and it is different for male and female. So here body mass index between 20 to 24.9, there is normal or desirable weight range, and if it is between 25 to 29.9, it is low relative risk, overweight. And if it is between 30 to 40, this is moderate risk or moderate obesity, and it is a grade 1 to obesity. And if it is more than 40, there is high risk or morbid obesity, the grade 3. Here, as we said, this is underweight, this is normal, and here we have overweight, and then obese and extremely obese. This depends on the body mass index. And this is the table. We have to take the height of the patient, and this is the feet by feet or by centimeters, and then we depend on the weight, whether by kilograms or by pounds. And then we have to check this is the levels, or this is the basal metabolic rate value. If the value is fall in the blue color, this is normal or underweight, sorry. If it is in the green color, it is normal. And if it is here in the yellow color, overweight. And if it is in this red color, obese. And if it is in the deep red color, this is the extremely obese patient. And we have to know how to convert the height, because some scales depend on the feet only, not on the centimeter. So this is the way to have the height conversion table. This is in centimeter and in inch, and here we have the height in feet. So other measure is using to measure the waist to hip ratio. And this is important to identify two types of obesity, as we said, whether it is lower or upper. If the ratio between the waist to hip, it is 0.7, this is normal. If the ratio is less than 0.7, there is lower body obesity. If it is more than 0.7, indicate upper obesity. Fat below the waist is more difficult to lose than above. And other measure to check for obesity is taking the skin fold thickness. About half of body fat is deposited under the skin, and the rest around the organs and between muscle fiber, but half of the body fat under the skin. So the fat is not distributed equally either under the skin throughout the body. Therefore, we have to select size and to compare with reference standard table to assess the fat thickness. First of all, we have, as we said, the skin fold thickness. It's indicating obesity. If it exceeds more than 25 millimeter in women, which is normally 10 to 20 millimeter, or if it is more than 20 millimeter in men, which is normally 7 to 18. So one of them, we have to check the triceps and biceps. But here, fatty arms appear to run in families, and it is alone is not enough to diagnose a case of obesity. We have to take the triceps and biceps in addition with other type of skin fold or other side of skin fold thickness. So as we said, there is triceps, biceps, and suprailiac. This is the suprailiac skin fold thickness measurement, the top of the hip bone just above the iliac crest. We have to take here we have to do our check by caliber, certain caliber. And we have abdominal skin fold thickness and the subscapular skin fold thickness. What are the medical complications? It is, as we said, a chronic disease and carry a lot of complications. First of all, it carries risk of adult onset diabetes. The higher prevalence found in obese patients, it is more than 2.9 times higher prevalence than the normal people. And fasting blood glucose increased by 2 mg per deciliter for each 10% above ideal body weight. And here the body is resistant to his own insulin. That's why he got hyperglycemia and diabetes. We call it type 2 diabetes or adult onset diabetes. Number 2, there is hypercholesteremia, is another risk. And the plasma triglyceride is increased by 2 mg per deciliter for each kilogram excess of body weight, and probably mainly increase the very low density lipoprotein, and the relative risk increase about 4-fold with obesity. So very higher increment in there is hypercholesteremia mainly in very low density lipoprotein. Hypertension and heart disease also, and it increases in linear fashion. And once the body weight increases, the hypertension increases with the same line, and even the heart disease. And the relative risk increases fivefold with obesity. Cancer, it carries high mortality from CA colon and CA prostate in male and CA prostate in female. These are the complications. Usually they are liable to have stroke, atherosclerosis of the coronary arteries, heart attacks, heart failure, and even kidney failure. And this table shows there is, as we said, a linear association between increasing weight. This is the body mass index increment, mild, low, moderate, and high and very high. Once it reaches a very high, and the risk is increases too in a linear fashion, as we said. And other complication is gallstone related to increased cholesterol synthesis, arthritis, gout, and undesirable social and psychological consequence of obesity. They might end with depression and even suicidal attempts. Obesity associated with a heavy menstrual blood flow and irregular cycle, and also there is a risk of infertility, and it carries a problem and a risk of decreased life expectancy by 11% for male, 7% for female, for the increment of 10%, while if the increment is more than 20%, so the decreased life expectancy occur also in male in more than 20 and 10 in female. But on the other hand, the risk of osteoporosis is lower with obesity. So diet reduction, how we control obesity? We have to have a balanced diet, to have a good energy diet, and to balance between the energy intake and energy expenditure. And this need to reduce body weight require negative energy balance. So many strategies include, first of all, diet, second is exercise, third is behavioral modification, and fourth is surgery. We will talk about first one, the diet. To lose 500 grams per week, the patient will reduce the calorie intake by 500 kilocalorie per day and maximum reach about 2 kilograms per month. So decrease the calorie intake daily by 500 kilocalorie, and within a month you will lose 2 kilograms. Or by adding exercise. In exercise, usually increase physical activity with depending on certain exercise. Also, it will lose about 500 kilocalorie per day, like in running for 45 minutes, or playing tennis 60 minutes, walking 75 minutes, and bicycling 90 minutes. Also, there is a behavioral modification. Eating only when hungry, stop with the first feeling of satiety, and we have to take small, regular, frequent meals. These are behavioral modification. Surgical treatment only for morbid obesity. And there are two operations, are creating a smaller bowel to reduce absorption of calories, or creating a small stomach to reduce reservoir for food. And even in these two ways, dietary treatment particularly effective for initial weight loss before operation, and it is advisable to take multivitamins, minerals, pills to prevent essential nutrient deficiency. The best approach to lose weight is to follow a balanced, mildly hypocaloric diet. Balanced, mildly hypocaloric diets. And here we have to collect any diet that is less than 1000 kilocalorie per day. But this should be used only under medical supervision to avoid a nutritional deficiency or any other of the elements deficiency. Repeated cycle of weight loss and regain, we call it yo-yo dieting. Yo-yo dieting here, this take longer time to lose weight and shorter time to regain it. When the cycle is repeated cycle. So it is not benign condition. It leads to nutritional inadequacy. Sometimes they got iron deficiency anemia, or zinc deficiency, and copper, selenium, and so on. Or other problem, they confused food habit and lost sensitivity to physiological hunger. They eat a lot even if they are not hungry, and diminish self-confidence because of regaining weight, and there is also the risk of coronary heart diseases and death. And this is the risk. Studies show that yo-yo dieting increases risk of cardiac arrest by 3.5%, and there is 66% increase coronary heart disease death. And this is the exercise. If we do exercise only, there is decreasing body weight, but diet only and followed by hyper-eating, as we said, there is increasing in weight or sometimes overweighting. And by doing diet and exercise, if there is overeating later on, also it increases again. So this is what we call the yo-yo diet. We will depend on the exercise only. It will cause a steady level of decreasing body weight. And if we have to add the diet to our protocol, it should be low calorie diet, but it is balanced and should be monitored and corrected with vitamins and minerals to avoid their loss. Thank you.